All right, I'm going to kickstart us off. I'm Jennifer Peterson. I am the communications person for the Prenatal to 25 team, and I have the privilege today to walk you through the legislative implementation webinar series with the team today. So thank you for being here. A few housekeeping items as we get started. Please mute yourself if you're not speaking. Raise your hand if you want to speak. This time is truly for you. We welcome any questions, comments, and feedback. However, during this presentation, since there are several presenters, we will hold those questions until the end for the Q&A session. But please, if you want to enter them into the chat, you are welcome to do that. We will go through them during that time. If we can't answer your question on this call, we will definitely follow up with you after the meeting. Just a disclaimer, this is a Zoom meeting is being recorded and will be posted to the HCA webpage. It is open to public disclosure, so please don't disclose any private or confidential information. We do have a series of presenters today, and we all look forward to hearing what's going on with them. But before we get started, I will turn it over to Diana for any additional thoughts before we get going.
Hi, everybody. Thank you for joining us today. And thank you, Jennifer, for the great intro. I am Diana Cockrell, and I serve as the section manager for prenatal through age 25 behavioral health in the Healthcare Authority. And that means today I get to support amazing work by amazing folks doing amazing things. Some context and framing for this particular update series that we're doing on implementation work. In 2022 legislative session, House Bill 1800 gave resources to the Healthcare Authority to support communications for the prenatal through age 25 behavioral health section. And this is our second year of being able to do this work, thanks to the support of our legislative partners, supporting us with communication support. And that is Jennifer, which we are blessed and grateful to have you on the team, Jennifer. We have about 10 to 15 implementation initiatives that come out of our sections from the past sessions that we're working on. We have a series of these where we cover different ones, some of them multiple times. Today's presentation and question and answer will be on our legislative initiatives, and want to give a nod that there are at least this many, if not double, the amount of programs, probably about 10 to 15 that the team also leads for Washington that are not implementation, but have moved into regular programs that we lead and operate on behalf of Washington Children, Youth, and Families. For each implementation presentation that you're going to hear, you'll hear a little bit about the language in the bill or the budget proviso that funded it, a rough timeline for the work, and where we are in the process of rolling it out. Please participate freely in chat as you'd like, and we'll either respond in chat if it's connected to legislative implementation and we can answer it here, or gather it to follow up with you if it's connected to other work or other thoughts that you have that you'd like to share, or we'll save it for the end of the presentation for a question and answer period. Thank you for joining us today. To the team, thank you for your courage and willingness to step into the challenge of presenting your work today in this format. With that, I will turn it back to you, Jennifer.
Okay. I am going to turn it over to Beth Tinker, who's going to go through the prenatal substance exposure program. And I know she was traveling from another meeting today. Beth, do we have you?
I am here.
Oh, yay.
I'm breathing a little heavy. I just ran in from the car, but I am here. I'm so sorry.
No, I'm glad you're able to join us.
You want me to just dive in, Jennifer? Okay.
Dive right on in.
Perfect. So I'm here to provide some context and information around our mandate, our legislative mandate, both funding and a directive to implement a pilot program for a pediatric transitional care facility. That may be a new term to folks. PTCF is a subtype of a RTF, a residential treatment facility. The legislative directive includes that this PTCF has to be in Spokane County, for which there's only one. And so what we are required to do is implement this 2-year pilot program around the services that are being provided in this PTCF, Pediatric Transitional Care Facility in Spokane, and also to evaluate this facility that is providing services both to newborns who have had prenatal exposure to a substance that may lead to physiologic dependence, as well as to their birth parent in those cases where birth parent is also staying at the PTCF, which is allowed and encouraged, but is not always appropriate or something that is feasible. The amount of funding is here on the slide, so you've probably already seen that. This is over 2 years, 5.5 million. Of that, 190,000 is specifically allocated for the evaluation. The remainder of that is going directly to the PTCF for providing the services at the facility. There on the right-hand side, you see what our specific requirements or directive are from the legislature. What are we required to look at in evaluation? I already mentioned that broadly. The efficacy and the outcomes and the impact of these services. Also, any information that we have and can summarize in terms of how those services were able to avoid more costly medical interventions. And then the second bucket I already covered. We are required to have a report submitted to the legislature with our findings. And that legislative report is due to the legislature by December 1st, 2024. Next slide, please. So where are we? The funding and the mandate both sort of went into effect July 1 of 2023. So we're about 2 months post that. We have executed the contract, finalized, signed by both organizations, both the HCA and the PTCF in August. So that was pretty an amazing turnaround. Super thankful to our contract staff and others who made that happen despite a really high volume of contracts. The initial payment to the PTCF is in process. We are still working. The second bucket just sort of illustrates we really did develop and co-developed a pretty detailed contract with the PTCF. In that contract includes quality of care and definitely focuses on evidence-based best practices and really a dyadic lens. So that's both the infant and also birth parent. We are in final negotiations for the other required contract, again, which is with Washington State University for the evaluation. We're getting close. We're just sort of in that final back and forth stage, I think. Hopefully, fingers crossed. We also co-designed that evaluation with WSU research team, really making sure that our agency priorities in terms of this population are presented in the evaluation. Next slide. So some of this now I've already said, but super appreciate Jennifer who put together these beautiful slides, just giving sort of a visual. So July, again, was when the mandate and funding began. You see there next in August, we executed the contract with the Pediatric Transitional Care Facility. September, we expect that we will finalize the contract with WSU. Over this 2-year time period, we have quarterly deliverables and reports and associated payments, both for the facility and also for WSU as the evaluation team. We will have quarterly meetings with both contractors, sort of standard, and then others ad hoc or as needed. We will get the final reports. Again, whenever we have a legislative report due in December, we have to back that up quite a bit for our own internal processes. So we actually have in the contracts that the reports are due to us from both WSU and the PTCF between July and August of 2024. And then we will submit that legislative report as directed by December 1, 2024.
Thank you, Beth. You did a miraculous job, and thank you again for sliding in right on time.
Thank you.
I will now turn it over to Rachel Baxter to talk about the Bridge program.
Hi, my name is Rachel Baxter, and I'm Behavioral Health Stable Housing Policy Lead for Transitional Aged Youth at HCA. I'm introducing the Bridge program that is contracted between North Star Advocates and the Healthcare Authority. The bridge was created as a statewide collaboration and education program for community-based housing providers, behavioral health discharge planners, inpatient and residential behavioral health, and community professionals. It is also facilitated by young people with lived experience of homelessness. This program aims to reduce the number of youth and young adults who become homeless within 3 to 12 months of exiting an inpatient behavioral health setting as an unaccompanied minor. The bridge does so by providing education to providers, and in the future, the bridge can assist young people identify safe and stable housing within their communities utilizing a return to community plan. In this presentation, when I refer to youth, I am identifying youth ages 12 to 18 and referring to young adults ages 18 through 24. Youth homelessness in this presentation is defined as youth and young adults who do not have safe or stable housing identified upon exiting a system of care. An unaccompanied minor is someone that is under the age of 18 living on their own in the streets or unsheltered, or residing in a place that is uninhabitable, such as a car, or staying with others and are doubled up or couch surfing. Next slide. On this slide, you will find links to reports and detailed background information that gives a better understanding of the current climate of transitional aged youth experiencing homelessness and how the bridge is essential to assisting our communities in ensuring safe and stable housing. Education prior to youth exiting an inpatient behavioral health setting. I want to briefly go over some key history and legislation that were important standing up the bridge program. In 2018, the Washington State Legislature enacted Substitute Senate Bill 6560 that was created to ensure systems of care discharge young people to safe and stable housing. Some progress has been made in this area since this was implemented, and more work remains to fulfill the promise of this reform. For HCA specifically, we are identifying and assisting with unaccompanied young people being discharged from inpatient behavioral health treatment. In this context, the term behavioral health includes acute care facilities, including hospitals, evaluation and treatment facilities, substance use disorder residential treatment facilities, Children's Long-Term Inpatient Program, also known as CLIP, Western and Eastern State Hospitals, and Long-Term Civil Commitment, or LTCC facilities. In January of 2020, the Washington State Department of Commerce Office of Homeless Youth, or OHY, released a report titled Improving Stability for Youth Exiting Systems of Care, which outlined recommendations towards achieving the goals set forth by Substitute Senate Bill 6560. OHY developed the report and its recommendations in collaboration with the Healthcare Authority, the Department of Children, Youth and Families, or DCYF, the Interagency Work Group on Youth Homelessness, the Department of Social and Health Services, specifically the Research and Data Analytics Department, community partners, and through holistic youth-centered co-design sessions with young people. The most recent data available shows that about 75% of young people exiting a Washington State system of care experience homelessness within 12 months of their discharge from an inpatient behavioral health program. The Bridge program is designed to change this trend so that young people who have the courage to enter treatment have safe and stable housing, in addition to accessing supports and outpatient services when they return to their community. In July 2021, HCA completed a report to establish best practice recommendations for strong and supportive communities for successful transitions from inpatient behavioral health facilities. Within this report, you will find that HCA recommended educational programs to identify best practices for transitional age youth discharge from inpatient facilities to discharge planners, managed care organizations, and community partners that work with young people during this stressful time. The report identifies the importance of provider and managed care organization collaboration and warm handoffs during care coordination to identify follow-up care, housing vouchers, natural supports, education, employment supports, and other basic needs such as food or ID cards. Additionally, this report emphasizes the importance of educating community providers on inclusivity, trauma-informed care, developmentally appropriate goal setting, identifying and addressing the stigma related to youth homelessness, and to identify systematic gaps that need additional innovation and support. Next slide. To support the recommendations outlined on the previous slide, the Bridge ensures discussions and topics presented during the monthly Bridge meetings are youth-centered and facilitated by those with lived experience of homelessness. The funding for the program comes in part from the Blake Bill and additional proviso funding during a special session of this year. Within engrossed substitute Senate Bill 5693, Section 215, it states funding was provided solely for the authority to continue and increase contract services to provide information and support related to safe housing and support services for youth exiting inpatient mental health and or substance use disorder facilities to stakeholders, inpatient treatment facilities, young people, and other community providers that serve unaccompanied youth and young adults. The Bridge program has implemented the data and reported findings requested of legislature by providing cross-system coordination and trainings that are youth-centered, establish education and awareness of resources, in addition to having conversations that are culturally and developmentally responsive, best practices for young people returning to their communities with behavioral health needs. Thus far, this has included developing relationships among service providers and giving a space unlike any other to discuss current trends, concerns, and to seek technical assistance. The Bridge also conducts a program spotlight during their monthly meetings to orient providers to other programs and resources that could benefit young people they are assisting. Some spotlights have included Kids Mental Health Washington, discussions regarding the Youth Diversion Infrastructure Program, also known as YDIP, with Away Home Washington, and some other organizations. In the future, the Bridge would like to establish a return to community customized planning, which will strengthen the process for young people who face housing instability upon discharge and for the youth to have the autonomy in deciding their goals to permanent housing. Each plan will include developmentally and culturally responsive safe housing options, supportive services, and enrichment opportunities to meet the young person's needs upon discharge. And lastly, the Bridge program envisions lasting reform, education, and securing additional resources. The Bridge will work in partnership with HCA in setting goals for future education and systematic change by identifying practice gaps, policies, and recommendations in connection that last and improve our community's understanding of housing supports essential to ensuring housing stability for those that have behavioral health needs. The next slide. The Bridge meetings are on the fourth Tuesday of each month from 1 to 2:30 p.m. To get involved and participate in the discussion or have your agency spotlighted during one of the monthly meetings, please visit the North Star Advocates website that's on this slide, as well as there's the executive director's information, Jim Theophilus, also on this slide, if you would like to connect with them further. Thank you.
Thank you, Rachel. And now let's turn it over to Paul Davis for WISE.
Good afternoon, everybody. Paul Davis from Healthcare Authority Division of Behavioral Health and Recovery, the Prenatal 225 team. So I'm going to talk to you about a couple initiatives, and I think I'd like to start by not assuming that everybody knows the details of how this stuff works. Every year they pass a bill that's got all of the funding in it. So that's Senate Bill 5187, as I think Rachel mentioned. And if you look at it, 215, Section 215 is where all the healthcare authorities funding goes, and then there's a whole bunch of subsections for that. So I got a couple of these. One of them is for WIBS and the other one is for ECHO, and we'll talk about both of those. So the first one I'm going to talk about is WIBS, and that's in subsection 95 of that big bill. So you're welcome to look at that and look at the details. I'll tell you that it gives us $250,000 a year for a couple of years to, as it says, have two behavioral health agencies are interested in offering or expanding wraparound with intensive services for children and youth. Might be used for recruiting, training, technical assistance, and other appropriate costs to develop capacity for those specialized services. And so let me start by just grounding you on what WISE is. We love ourselves some acronyms over here at the Healthcare Authority, and so you're going to see a number of those, and I'll do my best to spell those out. WISE stands for Wraparound with Intensive Services. And wraparound with intensive services, the purpose of that is to provide really intensive outpatient level services and not expect the family and the kid to get in their car and drive to those services, at an appointment convenient for the provider, but instead to provide them at a place that's convenient for the youth and family, whether that be at home in at the park or at the school. And the core services that we provide are just mental health services that are put in a wraparound kind of package of delivery. So think about getting individual therapy, family therapy, group therapy, medication management, and some other things like peer services, but not expected that you have to drive and meet an appointment, but it's something convenient to you and done where it's meaningful to you. We also expect that we're going to have an opportunity to get together and get pointed in the same direction on all the services that the kid is having. And so we use a child and family team meeting to get on the same page. And so that care coordination becomes a really important part of it. When we started doing WISE, I came on in 2015, didn't think a lot about serving a great number of kids that had autism or developmental disabilities, but it's become an increasing part of the kids that we serve over time. And so one of the services I didn't mention, and a couple of them, is like things that we don't provide as core services would be things like going to the doctor for a medical appointment, or the dentist, or if you're in school, you've got an individualized education plan, IEP, or maybe you're working with child welfare and they have some ideas of things that are going on. Trying to coordinate those things and point them in the same direction is important. And if you've got autism, one of the services that's often used is called applied behavioral analysis, or ABA, which is a science-based behavioral health treatment that's used to kind of help manage behaviors that tend to get in the way of the kids, and oftentimes manage things like aggressive behavior or behaviors that get in the way in other ways. So that's not something that's part of the WISE core services, but it's often coordinated by WISE. And our thought was, well, what if we had an ABA agency be a WISE agency? And that would be interesting. And it might make it so that, that we get better outcomes. So that's what we did. And we created Wraparound with Intensive Behavior Services, or WIBS. How do you get into it? Same thing as you get into with WISE. You got to be medicated. You got to be on Medicaid in Washington State. We have what's called a Child Adolescent Needs and Strengths, or CANS screen, that indicates that this is the right level of service for you. You need to have a mental health diagnosis, and if you don't meet the WISE screen algorithm, then the team can say, I think you fit anyway, and we do a clinical override. That happens sometimes, and that kind of indicates medical necessity, which says that the treatment fits the need. And so that medical necessity is determined by having the right diagnosis and that, yeah, this is the right level of need. Again, we have many kids that are very effective in WISE and don't need to be in this high level of intensity. And this was especially for kids that might not talk, might be very verbal, and oftentimes are aggressive and aren't a very good match for what our WISE program can do. Can we go to the next slide? So our partners and our timeline, we have one agency already in place. Lilac City is over in Spokane, and we've got them under contract. Molina is the managed care organization, or the MCO, that we originally partnered with to set this up. We'll be expanding it pretty soon, but we started with Molina, and Lilac City has already started to provide service in Spokane. And with this new funding from the legislature, we actually gave them some money to expand, and we're trying to work on getting them set up in Pierce County too. We have another agency that we're working with. We don't have it in place yet, but we're hoping to get King County, and there are larger agencies, so we'll hopefully get not just the first one, but the second one, but it's going to take some time. In addition, I think it's just important to note, we serve thousands of kids in WISE, and it's a lot. And a big number of these have big time needs. It's not expected that WIBS is going to meet the need of everybody that we got. And that's just a reality that we're facing. This is a kind of a pilot at this point to see if it works. And it's pretty clear that the demand is going to outstrip the supply at this point. And so I just want to do some level setting, is that while that we're very excited about this, we do expect that we're going to have more demand than supply. And we'll be working on this to kind of set it up over the next couple of years. And then I hope we can find a way to expand it, but we'll see how it goes. So that's WIBS, and expect we got many questions, and that's fine. And I think we'll get to those later. But I think if we can go to the next slide, I got the next part too. Echo and START, because we haven't thrown enough acronyms at you yet. And so ECHO, I have to write it out because I don't ever think of what it stands for. It stands for Extension and Community Healthcare Outcomes. That stands for ECHO. And START stands for Systemic Therapeutic Assessment, Resources, and Treatment. But what ECHO is, and the way I think of it, is it is an, I don't want to call it, I shouldn't call it an echo chamber, but that's the visual that I've got. In an echo session, it actually came from the medical world where we needed to get increased levels of expertise in places where you might not have it. I think it started in New Mexico. So think you're in rural New Mexico and you need somebody to have expertise on diabetes. You don't have anybody where you're at in that part of New Mexico. And they said, well, let's do something online, and let's have a group of people get online, and we'll have part of it be a lecture and part of it just be in case presentation. And that will increase the level of expertise in those people treating diabetes in remote New Mexico. Our thought was, well, why can't we do that with mental health? And we've done that. And we started it with first episode psychosis. And now we've done it with this thing too, where we've got WISE teams that don't have the kind of expertise that we have, that we need them to have in working with autism and developmental delays. And so that's what we do with this ECHO thing. So think about ECHO as it's a chance to talk, and not just ECHO, but that it gives me a way of remembering what it stands for. More recently, we actually got some funding, and in that big old bill 5187 that's got the budget, section 215, subsection 52 says that we've got some money to continue doing this ECHO training. And in this case, we had some language that said, we really suggest that you do this START training and add that to the ECHO training. START is a way to do care coordination along with just that expertise development. And so that's what ECHO and START are. Can we go to the next slide? Why do we do this? Well, we got 1 in 6 children between the ages of 3 and 17 that's indicated with a developmental disability. And children with developmental disabilities still have mental health needs. And until recently, I don't know that was well understood or accepted. It used to be that they were kind of excluded from getting mental health services, even though they had those mental health needs. And, that shouldn't be a surprise. If you work with somebody who's got autism or developmental delay, do you think they get trauma? Yes, absolutely they get trauma. And that's a big problem. Do they have anxiety? Absolutely they have anxiety. And you see them display that in anxiety in maybe a different way than kids without autism have it, but they certainly demonstrate it. And sometimes they can't demonstrate it with words. So we need that kind of thing. Can we go to the next slide? I got to make sure I'm not going too far, because at some point I pass this off to Kathleen. And these kids oftentimes are involved in a number of different kinds of systems. We mentioned some of them before, but if somebody's got autism, they oftentimes are involved in Developmental Disabilities Administration or DDA. Oftentimes they're part of Child Protective Services or foster care services. And unfortunately, sometimes they're part of juvenile rehabilitation, where they're involved in criminal systems. And that's while that's horrific, it's a reality that we deal with. And they're almost certainly involved with having an individualized education plan in schools. And many of them have medical needs that are complex. And so we have all of these different systems that kids are involved with. And so we need a way to make sure that we got not just the ability to clinically treat these kids that have specialized needs, but coordinate the care from the different levels that they're coming at. And the level of training we do for care coordinators needs to be expanded. We're pretty good at it, but this is a complex level of coordination. And so that's where some of that START training has. What slide are we on, Jen? Do I need to pass this off yet, or have I got one more?
You have one more.
I got one more. Okay. So, oh yeah. And so when I came out of grad school 100 years ago, I remember I was trained pretty well to do clinical work, and I could do family therapy and group therapy and individual therapy. And the amount of trainings that I had on working with kids with autism and developmental disabilities, I could count on 0 hands. And unfortunately, that's still the case today. As I'm hearing people coming out of grad school say, I didn't really get any training to work with ASD and IDD, you know, and especially one with kids that don't talk. We're pretty good at doing talk therapy, and if a kid doesn't talk, that's a real problem. And so we need to be able to do this kind of training to develop those skills that we cannot assume that clinicians are coming out of grad school or undergrad with that kind of training. And so that becomes really important for us to do. And now I think I get to pass off to Kathleen. Is that right?
You got it.
Yep. Thanks, Paul. As Paul talked about, we identified early on, I think that well, maybe not early on, but certainly eventually with WISE, that individual behavioral health providers or WISE providers lack the knowledge and the skills to work with individuals that are dual diagnosed with autism, an intellectual disability, and a mental health disorder. And to address that, that's where ECHO was born and initiated. Next slide. Oh, I'm on the orange one. Okay. And ECHO really provides that clinical expertise, and START aims at, as Paul said, to assist in the delivery of those recommendations. So we have many experts in our state, but ECHO really looks at utilizing those experts that have an expertise in autism and intellectual disability and behavioral health disorders. Next slide. So what does that look like? For ECHO, we have a contract with University of Washington and Seattle Autism Center, who are both recognized as experts in our state. Both provide that expertise for community behavioral health providers in really digging into what's available, what is recommended. I think that as a clinician, and I think Paul touched on this too, we do not get typically trained or provided education around working with individuals with dual diagnosis. Next slide. And we have 3 different ECHOs. It started out with just one, and it was aimed at looking at intellectual disabilities in a wraparound model. Typically, those providers that are presenting to ECHO are typically WISE providers, but they're not always. Sometimes an MCO might present a case, or an individual provider. And the ECHO SMEs will provide recommendations for those providers. Our second ECHO is medication management. It was really identified that providers lack that education and expertise in medication management for individuals with intellectual disability and behavioral health, that sometimes the approach needs to be different than somebody that is typically developing. And that started maybe about 6 months ago, and it's been widely accepted. Some of the providers that present there might be an individual provider versus a WISE provider. And our last one is resource and resource navigation. For many providers and families, community partners, they struggle with knowing the resources for IDD individuals and our youth. And to answer that, the resource and resource navigation was born, and it is very well received. And I think the first ECHO presentation for resources and resource navigation probably had around 200 people attending. So it was really well received and well attended. Katrina Davis is the expert that provides that ECHO. And she is from the Seattle Autism Clinic, does a great job. Next slide. And the components of teleecho, because it is all done telephonically. And what does that session look like? It usually looks like an introduction. So a WISE provider will do an introduction of a specific case, introduce utilizing just initials. And we'll talk about what that kiddo might look like, what the historical picture looks like, what medications the individual is on. So they introduce that individual to the group, and then the group will provide clarifying questions, and we'll have a case discussion, and we'll provide case recommendations. In there usually is a didactic. Sometimes it's presented before the case presentation, sometimes it's presented after. But that is usually what ECHO will look like, and recommendations are provided. And then that's where START follows up. START's intended, and this is the first year for START, but it's intended to follow up with those recommendations and ensure that individual continues to be provided those services that are recommended. And I think that's it for us.
Thank you, Kathleen and Paul. You guys are doing such great work. So it's good to know, and I know that people will have questions, so thank you. With that, we will move on to Children in Crisis with Diana Cockrell.
Hello. We're going to bring forth a conversation about House Bill 1580 that passed this last session. It's a bill called Children in Crisis. I want to be really clear that this, we're adding it because we get a lot of questions about it. And we want to make sure people know that this is work the governor's office is assigned and doing and leading. So we're sharing it here today to give you context of how we imagine this will work going forward, with the asterisk that we will follow the lead of the governor's team as they stand it up. State agencies, including HCA's role in this work, will be to support the governor's team's office in ensuring the goals in this bill are met. Agencies named in the partnership include the Department of Children, Youth, and Families, the Healthcare Authority, the Office of Financial Management, and the Department of Social Health Services. The bill goes on with more language than what you see here. There's a link on the slide, so you can go read all about the details and the work and outputs that will need to come from these teams as they stand up. We currently anticipate that the partnerships will look like continuing the strong partnerships across agencies that exist now in the current work of the Youth and Young Adult Housing Response Team, known as the YART, and the Kids Mental Health Washington Team, formerly known as the Youth Behavioral Health Navigators. Both of those are pieces of work that are standing up currently. You will hear about them if you come back to I believe our next series has both of those on it. And you can see them on our website. They are both named in the coordinate with in the bill. You'll see that on the slide. So in addition to supporting regional connections with similar work, there's the ones that are named here, and then we're imagining that through those teams, we will also want to make sure that the Lighthouse ESD navigators are connected with this work in the regional levels, as well as any of the substance use Blake bill work that is rolling out that can serve youth. The mobile response and stabilization crisis teams for children, youth, and families that are standing up regionally across the state, and other ongoing work in the regions that have shared goals. HCA's role in this will be ensuring partners are connected in the regional levels through the Kids Mental Health Washington initiative. As mentioned, it's formerly known as the Youth Behavioral Health Navigators work, and any other avenues that reflect and support the needs of the governor's office. I know there's some of the feedback infrastructure and places where if folks are having a difficult time in regions that don't have support stood up yet, or who are running into barriers in the regional level, there's some mechanisms in place in healthcare authority that may be utilized to help have that conversation and cross-agency partnership. But the first step in this rolling out will be the governor's office hiring for their lead in the work, and then learning together across all of our state agencies and current work with that new leader to activate the resources available in the bill to support young people that are experiencing behavioral health challenges, young people and their families who are currently unable to discharge safely from hospitals, and to do so with the supports they need to be safe and stable in that transition. That is what I have to share on 1580. And I believe that means we're going to roll into question and answer time.
You are correct. So I'm going to stop sharing so I can see the chat. And all of you guys.
While you look for questions, Jen, I will frame it up to just say, those of you who joined us, thank you. There's no wrong question. You may ask hard questions that we don't have answers to or need to follow up with you, or can give a little bit of context based on what we know at this point in time. But I really encourage the conversation. And if there's things that you've heard us talking about, the different things that we're implementing that you'd like from your seat in the world to say, are you paying attention to this thing, or how are you thinking about how these things go together? We're here for the questions with the asterisk. We may not be able to answer them today, but we truly believe that that wisdom is in the community and in the folks that are doing this work directly and or receiving or part of this work directly. We'd love to hear from you.
I have a question that I can kick off just to break the ice with the groups. For the bridge for Rachel, how do you see a provider or a community member participating in the bridge and getting started in that process?
Yeah, so to get started in that process, you would just want to reach out to the website at North Star Advocates, and there's a registration link there, and it will send you all of the invites to the monthly meetings. And I think for providers or individuals that want to participate with the bridge, it would be really beneficial if any community members have insight as to what is currently happening, either at one of the facilities, or that they've talked to a young person or they're a young person themselves and they want to share their experiences. Also, if they have resources themselves that they're aware of, they could share those. They could also help provide any sort of context or other programs that they're aware of that they think would be beneficial for young people when we're creating our return to community plans.
Thanks, Rachel. A question from the chat. Curious to know how each of these bodies of work are incorporating voices of youth and families' lived experience in keeping with our system of care values.
Jen, is it okay if I start?
Yes, please.
Yeah, I think that's a really important question. And one of the things I think we're pretty proud about is our ECHO Hub team has a number of people with lived experience and that are people with autism and developmental disabilities that actually provide the didactics and the case consultation as people are receiving this. And we're pretty proud of that, being able to have that kind of lived experience really inform the work. And, you know, they are able to ask pointed questions and answer pointed questions. And that's been, I think, an important part of our experience. Hey, Kathleen, I don't know if you want to add anything about that just at this point.
No, I think you covered it. What I jumped to was when Diana was talking about the YART team. That is also includes the individual youth. DCYF, I shouldn't say we, but DCYF takes those intake forms from the referring provider or person who's referring the youth. And then DCYF makes contact with that youth so that youth can steer their own care.
Yeah. And the thing I would say about WIBS is that it is a required component of any WISE team to have a certified peer counselor, either a family peer or a youth peer or both as part of the team. And that's an expectation for the WIBS team, is that we expect to have that lived experience be part of the team.
So regarding the bridge specifically, I would like to piggyback off of what Kathleen had brought up. So a lot of those diversion plans are youth-centered. For the bridge specifically, we do have those with lived experience of youth homelessness facilitating and coming up with the topics and administering the trainings during those meetings, as well as if there is a return to community plan or somebody's wanting any sort of technical assistance, that young person is also involved. So that way those goals are youth-centered.
No, Beth has left us, so I will leave it to Diana to round it out, the question.
I will say that we still have a lot to learn about how the Children in Crisis team rolls out. Kathleen, thank you for speaking to the YART. And I can say that on the Kids Mental Health Washington, those are multidisciplinary teams brought together with the young person and their family who drive the meeting and are supported in identifying what it is that what success looks like from that conversation. And then the coordinator pulls folks from the community together who may be able to meet that need with the youth and family all together. They drive it. Love that question, Rochelle.
Another question for Paul and Kathleen. How does an individual access ECHO?
You want to take that one, Paul?
Yeah, at this point, because we're so early in it, we had some kids kind of queued up that were really pretty high needs, and that's what started it. We're still working on the larger issue of how are we going to manage that pipeline, given how restricted the number of kids are going to be to get it. So we don't have it completely answered, and it's an absolutely fair question that I don't have a great answer just yet, but but we are certainly having those discussions about how we're managing it. I think many of you know that WISE as a whole has hundreds of kids waiting to get into to its services, and so this specialty service unfortunately is not any different. That we've got more demand than supply, and we're really struggling with that.
Yeah, Paul, were you talking about WIBS?
Oh yeah, I thought I was talking about WIBS. Were we talking about the ECHO? Did I miss it?
I think the question was ECHO. But
oh, for ECHO, I got a much better answer for that. If it's for ECHO, then we have because it's online, we have quite a bit more capacity, and so for that we have an email that it's an inbox that gets answered by Swee, and she says, here's how you present, and here's when we would love you to present. And so that is a place where our capacity, I think, is much better.
Thanks, Paul. I will give it a few more minutes for anyone else in the room who has any questions or feedback for us. If not, we're always reachable. You will have access to this deck. Everyone's email addresses are linked to it. So if you think of anything off of this call, we are always here, so reach out. I'm going to share my screen again just to close out some final thoughts. What's next? You can find all of this information on the prenatal website at HCA. It has the full schedule for the rest of the year. We will post the slides, the registration links, and these recordings. So you do have full access to those. The October presentation is October 10th. So we look forward to seeing you then. You definitely will hear from us between now and then to get signed up for the next round of projects that are waiting to be highlighted. With that, Diana, do you have any closing thoughts?
I will say for the WISE team that's on, take note of Rochelle's comment before we leave so that we've seen that additional coaching to figure out how to make sure that we are including parents in all of the ways possible. And I know you do tremendous work to help that happen. And there's so just noting that comment. Thank you, Rochelle, for making it the feedback. And thank you all for being here. Happy to hear feedback. Thank you, Jen. I just will reflect, I think, what Jen just shared. Happy to hear your feedback and thoughts on ways that we can make this more dynamic or less dynamic. And I hope to see you at our next one. We'll have different topics every time with some of the same sprinkled through that might be moving a little faster. So look forward to seeing you next time. Thank you for being here.
Thanks, everybody.